Good morning, everyone. Welcome to the House Healthcare Committee. It is Wednesday morning, and we have before us today our discussion where we will come to a final budget recommendation to House appropriations. So everyone has the spreadsheet in front of us, and it should be on the webpage for those following along. Our end goal is to have a final list. We're going to get to appropriations with the final items that we have on here prioritized as high, medium, and low. High is we recommend this as a committee as our top priorities and go down from there. And then for the high, I want us to also get to a point where we prioritize 1, 2, and 3. If possible.
What?
Where we also prioritize the high as number 1, number 2, number 3. Okay. Let's remember our guiding principles. No need to raise your hand. It's a committee discussion. I just hope that we don't talk over people and give everyone a chance to say what they want to say. And I want to start with a couple things that aren't necessarily in here. One thing in particular that isn't in here that I've asked our legislative council to work on and that we will be including in here, but you all haven't been involved in the conversation. So I want to update you. So if you remember, those few of us who were here last session, but we've also all been briefed on Act 167, which was passed last year, which involved Green Mountain Care Board and Agency of Human Services and some other things. But those two priorities were looking at our healthcare system and doing some reform work. And so part of it was in community engagement that Green Mountain Care Board has actually just hired a consultant to do. And so it's looking at all of our health hospital service areas and involving the community in what they're doing today, what's needed in that community for healthcare. Are there ways we can envision doing things differently? So that's one piece of work. Based on that work, they were in the act, it requires them to come back with a study or a report as to what could be needed for transformation within our healthcare system and how much that would cost. Since that time, there have been 2 hospitals, and I don't know who they are, I apologize, who have come forward and said, we actually want to start the transformation work. We want to start looking at this. And so myself, Senator Lyons, Diane Lamphere, the chair of House Appropriations, met with Green Mountain Care Board and AHS as they presented us a proposal to shift some of the money for community engagement into some transformation work. Both parties, AHS and Green Mountain Care Board, agreed with that shift. And so I'm asking Jen to draft, they provided some language. I'm asking Jen to work on that to include in our budget letter. Basically, what the language will say is AHS in consultation with Green Mountain Care Board will work on transformation planning with up to 4 hospitals. So in practice, we'll still be doing the community engagement, but for those up to 4 hospitals, that community engagement will lead into some transformation planning work. And really, for those who were here and working on this last year, that's kind of what we wanted in the original version of the bill. We wanted some transformation work to happen, but there was some pushback. And so that's why we took it out. This way, we're getting to the point where if they do some planning now, when they come back to us next year, we might be able to move faster on some of this stuff. So there's no money associated with it that hasn't already been appropriated. It's simply language to allow this piece to happen.
Where is the money coming?
So we appropriated the money last year in Act 167.
So what is transformation?
Well, we allocated money for Green Mountain Care Board to do in community engagement work with.
Right.
We're going to take some of that, which Green Mountain Care Board has agreed to, and shift it over to the transformation work. Still allowing enough money to do the community engagement we wanted.
Why do we even have to be involved?
Because the way, and I'm gonna let actually Jenny.
I'm not trying to stump you, I'm just asking.
Because we need language to allow that work to begin.
Really? Huh.
And do you want to give anything more than that?
Jennifer Carvey, Legislative Council. I'm not sure legally how much you need language to allow planning to occur. Because what you're really directing, what the language is suggesting is that the agency and Green Mountain Care Board do some planning and talk to each other. Although it does ask for a report back to the committees by next February. But there is also the potential that money will need to be moved from one entity in state government to another entity in state government. And that's the piece I'm working with the joint fiscal office to figure out.
Well, I understand the planning, so you need to, because it's being used in a different pot, we need to now have language in to allow that to happen.
And the quickest way to do this is in the budget. And so we have connected with the chairs of both House Appropriations and Senate Appropriations that they are comfortable with this language being put in our budget letter. Leslie?
So how much are we talking about?
I think it's about $600,000.
And if we put it in a budget, they won't have access to it until July.
No, because it's already been it was appropriated last session.
Okay. So just so just so I understand that right, then because it's in the 24 budget letter, it does refer to 23 activity. Is that how that works?
We'll need to talk to joint fiscal office about how to frame and phrase the effective date language for this, I think, depending on when the expectation is that the money would move. But yes, it is talking about FY23 budgeted money, but it's not actually changing the underlying state budget. It's just moving from just shifting one pot.
Yeah, I understand that shift. I'm just thinking about the timing because if there's someone ready to go now, I didn't
Yes.
want to wait until the 24
So
budget.
they're still going to do community work, engagement work, right? So there's still community engagement work that has to happen in these communities. But when they start doing that community engagement work and can start looking at transformation planning, this will allow all of that to happen in the proper time.
Okay.
All right.
Well, why, if we're planning transformation work, Green Mountain Care Board is, they're doing the community engagements and working on this transformation. Why are we letting a couple hospitals go off on their own and do what they, I guess, think that transformation is?
So we're not letting anyone go off on their own.
Okay.
So the process will be Green Mountain Care Board in consultation with AHS will be doing community engagement work based on what we laid out in statute in Act 167. AHS then in 167, that was supposed to be put into a report back to us
Yeah,
about what transformation could look like.
right.
Okay. AHS and Green Mountain Care Board came to us and said, we have 2 hospitals, potentially 4, that want to be able to do some planning around transformation. They're not going to actually transform, but
Okay,
they're doing planning. So they're going to take that community engagement work and do a plan so that for those hospitals, when they come back to us next year, they will have much more data behind and not even the data they would have. They would have a plan of what they think they need to do to transform their hospital area to best benefit the community.
okay.
And it's about $600,000 that would allow to help them do that work. In reality, what's going to happen, most likely, is there will have to be an ask from the legislature, potentially, to actually transform.
Okay, I don't care as much about the money as the process.
Yeah.
I just.
So no one's out on their
What
own.
you're doing is foreign to me. I mean, to me, you get the transformation, you figure it out, you start at once. Okay, this is what we're doing. But that's just, I get it.
Yeah, and I can forward their timeline and their chart that kind of shows their process if you, and I'm happy to talk offline as well.
Yeah, I'd be curious to see that.
Okay.
Thank you.
So just remind me, because with all we're going to talk about today, I might forget that. So that is, so Jen will work on that and we'll see the language before it goes in. All right. So I think what I would like to do is start with everything that's not in the governor's recommend. So it's the first page and a little bit of the second, well, I have a different format. It's the first page under the not governor's recommend. And prioritize these first. It might alter then once we look at the governor's recommend, but if we can talk about the values and the reasons why we want to prioritize these things, it might help us look at the governor's recommend as well. So we have some broad categories. We have increasing rates for primary care and specialty care, the first two rows. We have, and under free clinics, which is the third row, it says increase provider pay. That's not correct. It's increasing the money that goes to the free clinics to provide care to the patients.
That's where I got confused.
Yeah.
It's like provider care, huh?
We have EMS Medicaid rates. We have Sotera House. We have Vermont Care Partners, which is our DA system. And then we have the Home Health Agency. And then we have Bi-State. So really, a lot of this is increasing Medicaid rates. So let's maybe, well, let me take a step back. So of everything here, what are people's, priorities?
Can we start with questions?
Sure, let's start with questions.
So I was just looking at the bi-state piece and it says a legislative directive that VDA, DEVA continue current work to align Vermont. So I didn't know what that meant.
So if you remember, FQH, Bi-State came in and talked about the fact that there's a federal law that requires FQHCs to be paid a certain way by the state. And DEVA is not fully funding them per that federal statute. And so one of the requests from Bi-State is to provide some language that directs DEVA to align Vermont Medicaid payments with the federal law and guidelines. That is just a suggestion. It is something that we would agree or not agree to put in, and then we would have to.
You know why they're not doing it? Why DEVA's not doing it?
Probably because it's costly.
Just about money.
Yeah, I don't know. So let's focus on the money aspect first.
Sorry. Yeah.
Okay.
Yeah.
For the most part, I put a high priority on the reimbursements
Okay.
with some exceptions and some.
Well, do you just want to start at the top, Art, and tell us what you're thinking?
I can start the conversation.
Great.
Okay, the VMS and health first, I had as a high priority.
Okay.
The next one down, I had as a high priority.
Which is the specialty care?
Yep.
Okay.
Free clinics, I had a low priority.
Okay.
And again, I feel funny.
I know. And you know what? Let's just address that right now, right? Like,
Right.
this is hard work.
We'll create a thing to talk about.
Exactly.
So the EMS education for all, I had as a medium priority.
And that's going to be handled potentially by Commerce. So
Yeah.
let's just cross that out.
The next two, EMS increased Medicaid, both of those I had as a high priority.
Okay, so let me just clarify there. So I separated those two rows so you could see the difference. See that it's highlighted in red is 80%. So that number, 1.2 million for all funds, would be if we increased EMS rates to 80% of Medicare. Or the next row is if we do 100% of
I
Medicare.
didn't-
So it's one or the other. I apologize.
Okay. I think I'll keep the high on the 80
Okay,
and put the low on I'll change my little deal here. And then for me, again, the one-time fund for the EMS, I had that as low. And these were just done making just decisions on stuff.
and as the conversation evolves, it may change. So,
The Sotera thing I had as a low. Want Care Partners, I had as a medium, but just so much money.
Well, and so that one we're going to talk about now that it's.
All right, okay. Yeah, and you know, I sent you an email about Want Care Partner. I didn't do a lot of due diligence.
Okay.
I had the workforce bill, the tuition assistance loan is low.
Let's take that out because that will be something Commerce talks about.
Oh, okay. Commerce. Stop it right there. Okay. Mental health rate equity analysis, I had as medium.
Can I ask a question on that?
Yep.
What does that entail? Mental health rate equity analysis?
Yeah, so, let me find it. So it is. Okay. From Vermont Care Partners, and I will make sure you all, I apologize if you didn't get this. Our request for a 10% Medicaid rate increase is their priority. So that was the one we just talked about. But the Secretary of Human Services wants to see progress on the equity front as soon as possible. We are about to work with the Department of Health to clarify core services, which will help build a foundation for achieving equity along with a cost analysis by a national consultant, which is imminent. This request is an interim step as we work with the state to develop a more solid foundation of information to achieve improved equity in rates and services. That means. All right, Art, go ahead.
So yeah, under that is the home health agency, the LUPA. I had that as high.
Okay.
And the next one. I
Can you help
had
me? Yeah, sorry.
Oh, sorry,
Can
yeah,
you just
go,
help me understand those two, the home health agency and then the independently enrolled nursing services? Like, what are those differences?
So the home health agency are specifically, and Jill's not here, so I'm hoping to get this right, are the VNAs. And then there's some independent nursing services that also happen within the home health agency. And so if we increase the first one, and so this would, if you remember, we put in the BAA, increasing their rate to 90%, but that only takes us through June 30th. This would say, okay, we want them to have that 90% for the whole year. And it involves the second one, kind of have to do both together.
Now, these are the folks that visit the home?
Yes.
Yeah, good, okay. I hope I had that right.
Did that help, Leslie?
Yeah, I guess they're independent groups that are not Vermont, I'm not gonna get the name right, I'm sorry. Never mind. I know what I'm thinking, so I
Okay.
got it.
Okay.
But I see it as line 16. I had that as high, the home health agency, independent enrolled nurse.
Yep.
Basically, all the home health stuff I had is high.
Okay.
I think that's very important to keep that going.
90 or 100,
Pardon me?
90 or 100.
Oh, that's the same thing we have to pick.
Yes, darn it.
So the way, yes, it's one or the other.
Okay. I mean, I don't know, 90 or 100. I'll go with 100.
Okay. Let me just find that.
And then after that, the bi-state, I had as low because it's so much money. It's my call, I guess. I don't know.
Okay.
I didn't even rate it. I don't know.
Okay.
VSAC is workforce though, right?
I'm sorry?
You said VSAC and I think that's
Yeah,
workforce.
that can come out.
Forgivable loan.
Yep.
New forgivable.
That will be a commerce discussion.
Yeah, okay. But that
Right.
was my call.
So that's great. Thank you for getting us started. I appreciate you doing your homework. I know you were working on this last night. Let's go to Alyssa potentially to talk about the primary care.
Okay, so we have on our spreadsheets, I think the proposal originally to add 3.8% inflationary increase to the RBRVS schedule, fee schedules, which these are the fee schedules that essentially affect primary care and physician services. So we went back to them after they provided us with the numbers that are on our spreadsheet. And frankly, I think we were a little alarmed at the low number that was going to primary care.
This is that first row on our
Yeah,
spreadsheet.
first row. So I did ask them to, and I'm sorry, I'm trying to pull up the email here real quick. I did ask them if they could do another couple quick calculations. With the 3.8% that we asked for, what that would be is on the current, okay, so I'm not gonna try to explain conversion factors,
just
but I'm
put the
not.
numbers out there.
But it was like 104% of what Medicare uses currently. And I asked them to raise it to, for just the primary care piece,
Not specialty care.
not the specialty care. I asked them to raise it to 107% of Medicare and 110% of Medicare. And the numbers I got back were, so for 107%, and this is just under the primary care field, the gross would be 1,221,000, with 531,319 being general fund.
How much in the general fund? I'm sorry.
531,319. And then if they raised it to 110% of Medicare's conversion factor, the gross would be 1,755,041, with general fund being 763,092.
Do you know what percent that would be? If it's 110%, I'm just trying to make a connection between the 3.8% and.
So the 3.8% they had calculated would be 104%.
The 3.8% increase is 104%.
Yeah. So if they increased it, they gave the calculation when they gave us these numbers for the 3.8%, that it would be 104% of Medicare. And so
The top line of this, right?
that's just the top line.
Yep.
And then, so those are the numbers for if we went even further.
So basically, we're looking at state funds of the original 3.8% inflation request, state funds of $294,000. I would like to throw on the table, as we look at all of this together, that we actually raise that to 110% of Medicare. And so it would be state funds of 763,092 would be the number we're looking at when we do all of this. And that's just for primary care. The second line would stay the same.
What does that do for the federal funds?
Federal funds is, or what's the gross?
763 or 92.
That's the state.
The gross is 1755,041, so.
1.7. 1.7.
1.7 for gross, 763 for state, so about $1 million in federal funds.
Yeah.
So basically, if you just look at the gross numbers, they would go from 677,000 to 1.7 million for primary care.
Basically, it's a $500,000 add to what's here, the general fund.
Yes.
General fund,
General.
yes, which brings in, another additional See, yes, no, I'm not good at math. A lot more in federal funds. That works?
So how do we understand how this affects an individual practice?
Jessica, would you like to comment?
Jessica Barnard, Vermont Medical Society. I will say this is for, this line, top line, is for primary care services delivered by primary care clinicians. So it will be a subset of services and a subset of clinicians. And then these are for, there will be, within their whole fee schedule, within every service they provide, there will be a formula that determines of that whole amount of money, and DIVA sort of runs the numbers starting from that side. These are largely office visit codes. They would receive an increased reimbursement for each of those services that falls within that primary care service bucket. The dollar amount per service, DIVA could probably provide that for you, for the typical office visit, 999.
I'm saying 214.
214, they could give you the dollar amount of how that breaks out of what they're getting currently, what they would be getting.
What do you think, Alyssa? What would 214 cost? I mean, I'm wondering if we're talking about $10 or it's something.
It's a few dollars. It's a few dollars.
Few dollars per visit,
Few dollars per visit.
that they would get more.
Yeah,
But I guess if you have 100,000 visits or whatever, how many visits you get, it adds up for sure.
yeah. I mean,
I don't know how many times you do that code a year, but I get.
well, even if
That's
it's, I mean, think about it. Even if it's like $5 a visit, which I think it would probably be a little bit more. You do 20 of those visits,
Yeah.
that's,
And how does
speaking
this,
of not doing math, was that 100?
It's $100. I mean,
$100.
I mean, when we're thinking about
Yeah.
I hear the desperation that we're hearing. I just want to understand, it sounds like a big number.
Yeah.
But when you think about an entire state worth of primary care, how does it really does it have the effect that we would hope for? But maybe it's the best we can do. I get it.
And I will just say that, Medicare had 2% cut this year. So it does help make up for that 2% cut that they received from Medicare. And
We couldn't go higher. Could we go to 120%?
yeah, I mean, and also particularly, I like to think about pediatricians.
They get paid the worst.
They get paid the worst. And, I mean, like, it makes a difference on a well-child visit, I mean, it makes, even if it's like $10 per well-child check, when you're doing well-child checks all day long.
I think Topper had a comment.
Did you have something?
how does it affect, one care?
So it doesn't. So this one care is not involved in this, right?
And not, that these are all independent,
These are all, well, no, I mean, they're not just independent. So they're independent providers. They're, any primary care provider, right? That uses the code, except for FQHCs. This has nothing to do with one care.
okay.
So what would happen if we went to 120%?
We don't have those numbers and we're gonna stick at 110. For now, sorry.
Try, right? I said I could advocate, here I am.
I did.
Well,
Well, I'm just.
also look at the bottom, we also have people asking for 15 million.
Right.
So
Yeah.
Well, where's that?
the last row.
Partners,
Right on the bottom.
care partners?
And this also just,
Oh, well, that's my priorities.
yeah, go ahead. No. So this also, we've gotten some emails from OBGYNs. The two codes they primarily use for office visits is also part of primary care.
That top line.
Yeah. I was looking for the emails, but I can't find it.
Lori, what falls under specialty care, that next one?
Jessa, do you mind?
Jessica Barnard, Vermont Medical Society. So it's a whole range of services it's basically everything not in that special line for primary care services by primary care practices. It could include office visits by non-primary care clinicians, so endocrinology, cardiology, OBGYN. If it's not those certain types of visits, it's all your office procedures. So mole removals, OBGYN procedures that are not kind of your office visit, primary care visits.
Colonoscopy.
Some mental health, I believe there's a bucket actually of psychology services that falls in that. If you look at DIVA's way original chart when they presented sort of how this breaks down by clinician type. They gave you that breakdown that might have been for their budget recommend, but it would at least show you kind of how it falls out with different kinds of services. A lot of, certainly within that are things that specialists do that would still be considered, say, chronic care management. So, you're having your hypertension patient come back over time, or but if you're not a primary care provider doing those visits. And then it also would include some things like procedures.
Like a colonoscopy,
Colonoscopy, yes.
So it's more procedural based, not necessarily based on who you see?
It is both. It is based on if you are seeing a non-primary care provider, so any other type of clinician providing any code other than their subset of primary care codes. So it could be both like a check-in, a med check appointment with your cardiologist, but then it could also be a procedure. It can actually also include things primary care practices do that are not considered routine primary care. So it could include some, say you go to your primary care and they remove a mole rather than a dermatologist. In both cases, that falls in this specialty service bucket because it's not considered sort of a routine primary care visit.
Thank you.
So can I ask a question? Yeah.
If she's, we sent her to testify, so only if you're comfortable.
Sure, happy to, or I may defer to Diva if I can't answer the question.
It's really striking the difference in the numbers between, specialty care and primary care. And we've heard a lot, I don't know about in this committee, but out in the world about the sort of imbalance of primary care to specialty care and how we need more primary care. So for me, I'm not really intrigued by that because I want to go to primary care. So that's going to be a really low priority for me because right sizing primary care is important. And paying more for procedures, which already get a significant amount of money per procedure, doesn't seem to need that right now, in my opinion.
So is there a question there?
The question is that reasonable that the skew, I don't know. No, I guess not. It's a statement.
Okay.
I'll end there. It was maybe going to a question, but I answered it myself. Thank you.
Okay. Okay, so we're gonna look at this as if we're at 110% of primary care. So hopefully everyone has those new numbers. Anyone else have priorities they want to put on the table
For that?
for anything that is in the not governor's recommend?
I would like to put a priority in for the 3.8% for the specialty care practices
Okay.
as well.
So both.
To both.
Okay.
So keeping what we have on this for the specialty care, and then the 110% on primary care.
Okay.
Because I can tell you, specialists they're not making money.
Right.
They're not making money on Medicaid.
Right.
They're already.
Yeah, but their payer mixes. Well, anyway, we don't need to argue about it.
And I think I said yesterday, my other priority is increase Medicaid reimbursements to 100% for EMS.
Okay.
That is high priority for me. And oh gosh, sorry, I'm just looking here real quick what my other.
That's fine.
The forgivable loan, or is
We're
that
not-
moving
that's
to
commerce.
commerce? Okay, I must have missed that. Out of the room. Anyways, those are my two
Highest.
highest.
Okay. Dave?
My two highest, and I'm thinking more big picture and integrated care. Again, yesterday, I really thought a lot last night about long range, what we're trying to do with the system to support both primary and mental health and substance use care, because often those are the same people and often they're family members or us who need those services. And so I'm thinking about access, which is why I think my priority would be to support the Soteria request that expands bed capacity, care capacity using peers, which is a priority of ours. Also, we continue to hear about mental health and care being a huge pressure in our system, including in our emergency rooms that our primary care providers are dealing with. So I would definitely support an increase. I don't know that 10% is something we can afford, but I think I'd support a discussion on an appropriate rate increase for Vermont's care providers' request.
Okay.
Those are my two priorities.
Are we supposed to be getting down to two?
No.
I have 4 priorities
Okay, go ahead.
that are high.
Okay.
I have 4 high priorities. The 110% of primary care, sure. Increasing the EMS at 100%.
Okay.
I'd like to increase the Vermont Care Partners at 3.8% at the MEI, although I'm willing to negotiate with that on that one. But we did 8% last year, so that adds another almost 4%. And I'm combining the home health thing just because I am. And that's my other priority at 100%.
Okay, so I just got clarification from Jill Olson on this. So the 2 rows for home health is say 90%, right? So they go together and that would get them through 90% through 2020, all of 2023. And then if we added the bottom row in the next, if we added the next 2 rows of 100%, that's the incremental from 90 to 100 for the rest for 2023. Does that make sense? So they all go together.
All 4 of them?
Yes. Well, they don't have to. So the first 2 are 90%, right? So it gets us for the full year for what we did in the BAA. And then if we wanted another 10% to get to 100% for the full year, that would be the next 2.
I'm going to go with that just for discussion.
Okay.
Which one?
Bottom 2 at 100%.
I'll do the same.
So what we really need to do, Leslie, would be the first 2 are what we need to do to get to the full year of 90%.
Okay.
And then we could do the second 2 to get that incremental 10% if we wanted to
In the next year.
Okay,
in 2023.
yeah.
I just also want to remind everyone, which we did not have testimony on this, but part of the governor's recommend that is not in our bill, our part, is for, it's not in the governor's recommend, it's actually in statute that the provider tax that home health pays of 6.1 million is sunsetting this year. And so that is home health's priority, is the 6.1 million, and then this would be an additional ask. Wait, did you finish your 4, Leslie?
I did. I'm trying to understand the home health request in the context of the provider tax. Like maybe we use this other money elsewhere, and that might be a good thing.
Right. So the home health, when the provider tax sunsets, they will not be paying $6.1 million a year in provider tax. And so that 6.1 million can now be used in home health to what they needed to provide care.
Which is way more than anything.
Right. So my recommend would be, and I'm trying not to put this out here before you are, but my recommend would be that we put a comment in our note that we support the provider tax sunsetting and that we add the first 2 rows so that for 2023, they're at 90% of Medicare for the whole year.
With home health, yeah.
Yes.
And a question about the provider tax, when it sunsets, so that it sunsets for 24.
Sunsets permanently.
For 20, but it will start in 24.
It'll start in the next budget year,
So they're still paying it in 23 or however that.
till June.
Yeah, until this fiscal year.
Right. And I don't know if they pay it all at once or if it's
Whatever.
paying, or I don't know the specifics of that. And I will say, I would also like our committee to put forth language in this bill that, I'm gonna look to Bobby, who has some great ways with language. But it's, and to work with Jen, but it's that it is our committee's, intent that, you know, we can't keep underfunding our community-based systems, and that includes underfunding Medicaid rates. I mean, and that's something we will agree on, but I want to throw it out there as, you know, everything we've heard is we have been underfunding Medicaid for years. And what that does is it makes the provider struggle to provide good care, limits access because providers stop providing Medicaid care, and it increases cost on the commercial side.
Ultimately, serving fewer people
Right.
who are the most vulnerable and end up in
Right.
emergency rooms.
Right.
And then those providers come to us saying,
Right,
we can't.
right. We have to shift our focus, right, to preventative care. And we have to fund it in order for the hospital cost to eventually go down.
And do we have an opinion about what we'd like that connected to, like compared to Medicare? I mean, in this kind of note, do we want to?
No, let's work through this first and then come back to that.
Okay,
You going?
my turn.
Yeah, absolutely.
The home health agency is my number one. And the rest of them, it's not gonna be number one, two, three, or anything. Excuse me, I'll do that later. I rated, on the first page, the primary care high, the specialty care high. If I was gonna say number two, I'd probably say the free clinics need help, but I rated it high anyway. I rated the EMS 80% medium, and I rated the EMS 100% high. The one-time funding, I rated medium. Satoria House, I rated high. More Care Partners, I rated high. The first one, the 10%. The mental health equity, I rated high. And by state, I rated high. All the rest, we don't have to rate, am I right?
Correct.
So in other words,
Everything's a whole.
except for, I got a couple of mediums.
Copper's got some money trees.
Well, I'm talking about policy too.
Yeah, I know.
What I think need, if we don't act, the healthcare system is gonna collapse.
I agree with you more.
And, so that's how I feel personally,
Okay.
probably not gonna blow the world.
Alan?
Okay, I definitely have got home health.
Okay,
That's most of our area in my district, so
okay,
we do it. That's number one.
okay,
Number two, the 10% Medicaid rate.
okay.
Then I would go with the
I'm sorry, number two, is it the,
10% Medicaid rate increase.
for Care Partners?
I'm
Okay.
going backwards, yeah.
That's fine, no, that's fine, that's fine.
And I would say the increase in Medicaid reimbursement rates, I would go the 100% instead of the 80. And the
For
primary.
EMS?
Yeah,
Okay,
and the primary care, I just get confused between primary care and specialty care. And I'd want to know exactly how that was, but
okay.
that's on the
That's
list,
well.
but it's
Okay. Okay, so, do you want to go or? You don't have to yet.
Oh, no, it's just so hard, but.
I know, it is.
But I mean, I could say that I'm in agreement with a lot of what Penny just said. I'm the 100% for the EMS.
Okay,
I'm supportive of that. Soteria House too, because I feel like for the bang for the buck, what they providing 4 extra beds for
yeah,
$1 million, you know, I don't have to explain, but I think it's a really good program. the primary and specialty care, I consider that a priority too. And I think that the FQHCs, I want to give them the support they need, and also the home health. I guess that's 5 things that I just listed, but those are some of my priorities too.
Okay. So based on everything that everyone said so far, I want to throw some things on the table. What I'd like to do is on the EMS, cross out the 80%. Most people said 100%, so let's take 80% off. And if we do anything, it'll be at the 100%. On the home health, let's talk about that one a little bit more because it's high for a lot of people. Is it high? So again, remember in the big picture of everything we're doing, and we're going to have to prioritize this even more, with the governor's recommend. So all of you who said high for home health, remembering the provider tax over here, 6 million, are you saying do the first 2 lines and the second 2 lines, or just the first 2? So it'd be the 6 million in provider tax over here, and then it would be another 1.3 million for us to get to 90% of Medicare for the whole year. And another 1.3 million, 4 million to get to the 100%, incremental 10% to get 100%. I think what I would like to put on the table is that we put the 90% as high for everyone who said it was high, which was pretty much everyone. And we hold that the second 2 rows kind of over here as we continue our discussions.
I agree with that, Madam Chair.
I just wanted to clarify that I did not rank it high, not because it is not a high priority for me. It's just that I was under the impression that they really just wanted the sunset.
That is their highest priority.
That is their highest priority.
Yeah, it wasn't high for me either.
So if I understand though, it's about $350,000 of general funds of the top 2 lines?
Yes,
Which is not a huge amount of money. Right.
but on top of the 6.1.
No, I get it, but yeah.
So, and we'll hold the other 2 over here in our sandbox.
And
So we
why
get
are
to
we
play.
doing that word, just so I understand? I'm not getting what we're doing here.
So one of the pieces that is not on here is that home health provider tax is sunsetting.
Provider what tax?
Tax. They pay $6.1 million a year in provider tax. That is sunsetting. So they will have that money to use for their services. That is home health priority based on the testimony that was given.
Okay.
And then this is an additional ask. So in order to meet all of, or most of our priorities, I'm just asking that we do the first 9 at 90%, first 2 lines at 90%.
All right.
But let's hold the other ones over here. I'm not saying we're taking
Okay,
them off.
yeah, okay.
Okay,
That's fair.
Hey, Lori,
yeah.
there is one item that it's a very small ticket item, but I think it's important. I'm always like talking about practice improvement and administrative improvements. We're investing in sustainability in a lot of these practices. I think the EMS line, the last EMS line on the first page is $100,000 to assist in the study for administrative support.
You want to know what that is? Or are you saying that and bring it up?
Yeah, I assume it's funding to assist in studying.
Yeah.
How much administrative support they need, or kind of to look into that. And to me, that sounds like they want to take a look at where they could improve their practices, and that's something I would support.
So thank you for that. And Drew Hazelton, who was in here, talked about it. So it's in H263, which is a bill we have not taken up yet, but it's the study, which is outlined in here.
Are we sure that that's not it? That wasn't, the H263 wasn't tagged with the education?
It is No, The education funding is not in H263.
Okay, good.
So the study for $100,000, that is in H263, that if we move forward with it, I would ask Jen to take out of 263 and we would put it in our budget letter. Created the Regional Emergency Medical Services Coordination Study Committee to assess the current EMS district structure and the current level and cost of service in each district. And if you remember Drew talking about, each district is really, really struggling because we are not paying anywhere near cost. And everyone does it differently, which is okay. But what's happening is they can't, the EMS commission isn't able to get all the data from all of the various EMS areas to determine what really everyone needs to be a high-performing provider for our most vulnerable. And so the 100,000 would actually allow them to hire an outside consultant to help them with that study. And it is one of his highest priorities. And just so the membership would be someone from the House of Representatives, someone from the Senate, the EMS chief in the Department of Health, Commissioner of Department of Health or designee, Commissioner of Public Safety or designee, someone from Vermont League of Cities and Towns, a member who is a volunteer emergency medical technician or paramedic, a member of VAS, a member of the Vermont State Firefighters Association, Professional Firefighters Association, one member appointed by the statewide EMS medical director, one member by the EMS Education Council, and a whole lot more.
I am impressed with that request. I wish we saw more requests like that really promote coordination and innovative ways to collaborate, especially when people are short on resources. And so I would definitely ask that we support that request.
Okay.
So I'd like to comment on that. I think, I'm really glad that you brought that up. I think it's really important. I see the EMS system as the first step in the continuum of care for our entire population, not just they're vulnerable at the moment that they're needed, but it can be anybody, people having a heart attack, people in trauma, people having mental health issues. So I totally support this and have moved it to high.
Okay.
Thank you.
So let's talk about Vermont Care Partners. So the request they put in was for 10%. I'm not going to that spreadsheet. Nolan put together a spreadsheet, and he should be in here soon in case we have any questions, that allows us to look at each 1%, so we could, put in a number. So a lot of people put this as high. Some put it as high. And the two that commented the most suggested that it's not 10%. They would support it at a lower amount. So the 10% is what we see here, which is 15.6 million all funds, 6.8 million general funds. So if we took it down to, you said 3%, I'm just going to round up.
3.8, just
3.8%.
Yeah.
So 3.8% would be,
In the context that they got 8% last year, so in 2 years it'll be almost 12%.
so gross, so all funds would be 5.9 million and general funds would be close to 2.8 million.
At 3.8.
3.8. Let's just do a round number. Can we go to 4?
It was just at 4.
I know. Let's just keep it at 4. So 4 is 6.2 million gross, 2.9 million general fund. What do people think about that?
Skeptical.
Skeptical?
I'm very familiar with NCSS up in home, and I know how important they are. And I think if I remember right, Vermont Healthcare's got like 16 or 18 different agencies that they work with in the state. So we're covering the whole state of Vermont here. So.
But that's with home health. Vermont Care Partners is our mental health system.
Right, mental health.
Yes.
So, I don't know, I don't want to cut it too low, but
You don't want to cut the mental health system too low.
that's right.
Okay, got it. Anyone else?
I don't either.
You don't either? Okay. So do you have, Alyssa?
Oh, just so I'm understanding, it's a high priority for you that it is higher.
I think so.
Okay.
Higher
Okay.
than 10%?
Oh, no,
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 no, higher than 4.
The 3.8 or the 4.
Okay.
You're good with the 4, is that what you're saying?
You're not good with, you
Wants
want
to
I can,
to.
I can live with it if everybody else does, but
I can't live
we
with
talked
that.
about mental health for so long.
Yeah.
I don't wanna,
Okay, so again, let's keep this, and we're not making any
No, no.
decisions, but we need to keep this in context with all the other
I know.
requests. So right now, primary care and specialty care and home health is the highest priority for more people than not.
Okay, and then I'm thinking about how those work together, right? Like we have initiatives where we are bringing mental health and substance use care into primary care and thinking holistically about our system and supporting that through funding. And when I look at the other items that we have, and I don't want to get ahead of ourselves, but later, when I look at where the administration is investing in that, I don't see a lot of innovation or investments in direct mental health services or those providers. So when I think about where the system is crumbling, as myself, both a patient and someone who's, worked with providers for over, decades, I don't see a lot of equity in terms of the investment and support. And so I'm coming at it from that perspective. I think 3.8%.
But we're talking about 4, so let's just go to.
Okay, 4%. I think that keeps folks treading water, right? And I think when we look at, the frequency of how everybody experiences mental health, look at the data, 1 in 4 people. Look at yourself over the last couple years, okay? And look at your family members and how your mental health was. And think about how many times you thought about.
So you okay with the 4 or are you looking?
No,
for medium?
I will suggest 7.
Okay, so what's 7? So I'm just gonna focus on the general fund. 4 is 3.9, 7 is 5 million. And I would say, Daisy, my perspective on what you just said is absolutely right. But everything we're doing here is just treading water for everyone. Let's be realistic.
I understand that, but I want to be a voice for mental health and we're doing 110% for primary and specialty. So I just want to lift up mental health and all of that.
And I just want to say that I'm coming from the perspective of last year, we did 8%.
I'd like to come from the perspective of specialty care, which you just mentioned, that I haven't heard any testimony about specialty care. Even though I know they're represented by Vermont Medical Society, no one's come in here and said, we're desperate. We've heard a lot of desperation other places. I could very easily support moving up to a 7% and removing that money from specialty care.
Removing.
I don't.
What's 7%? What's the
I
number?
agree with that. 5 million.
5 million gross.
5 million general fund. All right, so
Million less than what 10% is.
10% is what's on here.
They-
6.7
Yeah. So it's a
million.
million less.
The 1,000,007 less.
So we did an 8,
5 million general, what's,
we
Are
increased
we
that
in a-
8% last year.
Yeah.
Yes, we've increased. We did 8% last year and we did very little for others.
Yeah,
So I'm sorry, what was your question?
I think 4 is fair, frankly.
All right, so let's hold this.
Yeah,
Okay,
So 5 is 3.6%. So let's hold this. All right,
all right,
let's
now,
hold.
it's on hold. Now, I want to talk about, since we're going to pick out things, free clinics. These people do a tremendous job. Most of them are volunteers that are in there. And in the whole scheme of things, $453,000 to me is not a big deal, and it will go a heck of a long way to help those people. So that's why I rated it high. It's, when we're talking millions and millions of
Right.
dollars on somebody else.
I think that is
These
very,
people
no brainer personally.
Yeah, that's how I feel too.
All right, let's go to, since we've had a great conversation on that and did come to some decisions, let's go to governor's recommend, because it's all got to fit together. First one we have is the dental rate increase with the cap increasing to 1,500 since it is the same dollar amount.
Question on that, Lori.
Yes,
Why is there no general fund shown?
I was just asking myself that question. Nolan, welcome.
Hi.
Why is there no dental rate increase general fund?
Sorry, what page? What
So
number?
we're under the number sections, B 307. Dental rate increase, global commitment is 13 million. What's the general fund?
Oh, you know why? Because it's showing up as, if you look off on the side, the appropriations to the global commitment, it's already matched. You want to know what the general fund is? I
Yes.
can tell you that.
Yes,
But
please. Actually, we probably have
This
it
is
in
where
our.
they make like. the soup and
They make the
AHS, and then they,
Yeah, this is the soup.
okay.
But if you want to know the general fund, it is 5.7 million.
So I'm not quite understanding what you just did over there.
So if you look on the row that says dental rate increase.
Yep.
13.1 million is
Yep.
all funds.
Yep.
Put 5.7 million in the state funds.
Does that make the global commitment go less?
No.
No, it's just telling you what the general fund share is, just so you know.
So ignore the federal funds, the Medicaid investment, and the other special funds. Ignore those four columns. What we're really looking at is the entire amount that will go to it, and then the general fund. And anything that is not general fund is coming somewhere from the federal government.
Right.
Does that help, Leslie?
I guess so, but there's still a Medicaid general fund that's 13. That's the same number as all funds.
Right, because so that's the all funds. 5.7 million of it though is state fund. Just ignore those columns. Like,
So it's not going to be reduced? I mean, it's not
No.
going to be reduced
So
by.
you're gonna get 13 million, but it's only costing the state 5.7.
right,
You're gonna
Right,
get federal match, it's just not showing up that way on the chart.
yes.
but so would that, so I'm just saying, would the 13 under the global commitment go down by?
No,
No.
So that's where I'm stuck.
Because this
Don't look at it.
includes that. This includes that.
Okay.
yeah,
And so does this.
ignore those columns.
So we all in agreement with that?
I'm all for the dental one. I mean, is anyone not for dental? Okay,
And then
So that takes care
so that's a yes. Okay. And then the dental rates for DS and CRT, that's the moving of money, so we're gonna say yes. Okay. So now the remaining ones that we're gonna talk about, and we can go through the same process, kind of tell me what your priorities are. We have the drug coverage changes with pharmacy benefits. So that's where DEVA is reducing their budget in order to make their numbers work by what they classify as the least harmful piece. Again, these are those 3 drugs we talked about yesterday that are over the counter. That if this goes away, those people will pay much higher prices out of pocket for these drugs. Yet these are people on Medicaid. And, are some of our most vulnerable Vermonters.
I'm a no.
So,
I'm a no.
okay, wait, I don't want it, so I'm just laying all that out. So there's a couple different rows on that, but it's all the same package. So there's that. Then they're also redoing the 500,000 reduction to remove the cost sharing, which we heard testimony that it's going to take work from them. And they have these redeterminations to happen. Okay, so there's that one. Then there's the mobile crisis response. There's the maintaining 988, so an additional 275,000 in the base budget. Peer support credentialing and the therapeutic alternatives to the EDs in the Northeast Kingdom.
And the cost shift.
And the what?
Cost share, or cost sharing reduction.
Yes, the 500,000.
I'm
Okay, cool.
strongly in favor of all of the spends and strongly opposed to all of the cost-cutting measures.
Okay, so
They are minuscule, and yet they provide a great benefit to a small number of the most vulnerable people.
okay,
And I also don't believe that particularly the prescription or, the over-the-counter,
yeah,
I don't believe that will save anything because I really do think that people will then just be switched to a prescription and they'll just end up paying the prescription.
right.
For sure.
I definitely agree with Alyssa on the, Representative Black on the, prescriptions. I mean, when I go to my I get treatment at my F2HC, and when I go there, my provider always prescribes over-the-counter first, especially for pain relief. And it would impact me. And I know the cost of those things, like we heard yesterday in testimony, is not insignificant. I'm with you.
Okay. How about the rest of them? Is there anything you would want more than another? And if you're not ready to answer that, someone can take in what they're thinking on the governor's recommend.
The mental health up in the Northeast Kingdom is big.
Here, here.
Oh,
That's the very last.
Yeah.
Is there a general fund on that one?
For which one?
The therapeutic alternatives to EDs in the Northeast Kingdom?
Where is that?
Very
Oh,
last
there it
one.
is. Yeah.
14.
Yeah.
Where's that?
It's the very last one under.
B 314.
General fund.
I don't know anything about it. Oh, the general fund. Oh, yeah. So because it's global fund, it's the same issue that the global, I'll tell you what it would be.
That ratio is like 45, 55 at the time,
0.4348.
like 4348.
Just multiply, anytime you want to know general fund, just multiply times 0.4348.
To that,
Okay, but I'm gonna let you do the math and tell us. So hold on.
I was
Got the
You
calculator.
missed it earlier when I said, oh, it's,
Oh, maybe.
it's not in our list.
So it's 690,561.
690,000. Okay.
690, 562.
5.6 what?
562.
Okay. Alyssa?
may I ask a question related to the global commitment on the mobile crisis response? It does have a breakdown of state and federal, but then it also has global commitment. Are we saying that these state funds are actually more, because we need to take out 4?
No, what they're doing is they're paying for different components of it in different funding sources.
Again,
I wouldn't mess with it.
we're not gonna pay attention to those columns. It's all funds and state general funds. Because we don't care how it's matched, right? It'll get matched.
It has to do with the administrative, what they can count on the different buckets for match.
Mm-hmm.
I wouldn't mess with it because they could, how they can implement the program.
So I have a question about the suicide prevention line.
Yes.
It's not much money, but isn't it already in their budget, or why is it new?
So it's, so yes, they have 475,000 in their base budget. And then this is additional funding that's needed to keep it going. And this would be base funding as
So then it
well.
becomes base funding.
This will as well.
Okay.
Which line are you looking at?
This one, B14, maintain.
No.
So this is an additional to.
But hold on, what?
I'm not sure that it is additional funding. I think,
It is additional funding. I checked with them.
okay.
Yeah.
What's the concept now, Kevin, or you may have already known, but the drug coverage piece is in 3 different sections.
Yes.
Okay, and it's 1.8 million total. I could have lumped them together
That's
on the
okay.
chart and I
Yep.
missed that one.
Yep.
Sorry about that.
All right. we're gonna change it up on this one. Because it seems like everyone thinks everything in the governor's recommend is important. So do we have,
Except for the drug thing.
Well, yeah,
well, so, okay, so does anyone want to, how does everyone feel about saying no to the decrease in the drug?
I'm good with that.
Yes.
I'm
yeah,
not.
well,
I wa-
you're not.
I want to keep that in, yeah.
Okay,
I feel like we have to pick our poison.
okay,
It's about picking your poison here. And, you know, if you take the $500,000 and save that money, you almost pay for the therapeutic place up in the Northeast Kingdom. That's my thought process.
okay, so you're a no, and we're gonna go with majority wins.
And,
You're a
right,
no.
oh, I understand.
You're a no on both the drug coverage changes and the cost sharing.
Recommended by the folks in the administration.
Okay, so the drug coverage changes the pharmacy benefit. Who is in,
Who wants to remove it?
who wants to not accept the governor's proposal?
Not accepted.
Not accept the governor's proposal. Okay, so Pete, how about the 500,000?
For the CRT? Or no, we,
Cost sharing program where Diva said it's gonna take work and they just, I mean, really, they need to do so my worry would be, is this even gonna happen? Is it gonna be done well? Like, you know, are people gonna be hurt because they're really focused on redeterminations? And this is only, I mean, I get it, it pays for almost all of the therapeutic, but it's
Poison.
not much.
I'll leave it as it is.
So those who wanna leave it as
are you
is,
thinking, so what's your, are you willing to say your thought?
my thought is that we do not accept it.
Okay, because you're worried if we do,
That they're not going to be able to do it. It hurts Vermonters. We don't know the effect it's going, I shouldn't say it hurts them. We don't know the effect it's going to have. Their priority is redeterminations.
so if we leave, if we don't take it out, what happens?
They have to
Come up with.
they have to make this reduction happen, which requires technical and staff.
They have to do this program. So in other words, we're removing the program.
We were removing the reduction in the program and it will just stay as is. Bobby,
Well, if we let them do that, then that just means that other people's co-pays are gonna go up, right? And they're,
potentially.
yeah,
I mean, they didn't really tell us
yeah.
Yeah, I mean, I'm feeling like,
what happened.
The other thing, in addition to everything that you said, I just keep coming back to, these federal subsidies for premium assistance will go away. And then this program will not be in place. And I believe the testimony we received said, well, we'll have to come up with something else then. But I don't want to risk having to come up with something else in a couple of years.
I don't either, but the other point is that we support these people making all these other decisions. And all of a sudden they come up with this and we don't support that one. They must know what they're doing.
I'm gonna say that I completely support what Viva does. They are an amazing organization. They do a lot of work for Vermonters and they do not have the appropriate amount of staff to do that work. And at the same time, I heard loud and clear from them that this and the drug coverage was put in as a mechanism to meet their budget number they were asked to meet. And I did not hear the benefits at all of us reducing this. I only heard what could be negatives to people. So all those in favor of I'm going to go back to my original, of accepting the governor's proposal, meaning that this program will be reduced.
so a yes vote.
A yes vote right now means you want to keep it as is.
In the
Yeah.
proposal.
Yes.
I do.
Which
Okay.
is a $500,000 cut.
Yes. Those who want to reject it.
Reject it.
Okay.
This is both, right?
Yes,
I meant-
but can we take a break in like right now or 5 minutes? Okay, let's take a break at 10:30. Thank you for that reminder. I would have just kept going. Bobby?
So I just want to be clear, we're rejecting both the 1.7 million for the drug coverage and the 500,000 for cost sharing, right?
Yes.
Actually, 1.8 for the drug coverage.
Yeah,
Because it's the 3 lines.
yeah, okay. Right.
We're all highly in favor of the dental. All right, so now we have mobile crisis, the 988 line, peer support credentialing, and therapeutic alternatives. Again, we can keep everything in here, right? But we will prioritize.
I like the peer support. I don't like the peer support. I like the therapeutic placing.
Okay,
I love that, and I love the peer credentialing.
so is there anyone that doesn't, I mean, how am I gonna phrase this? Is there anyone that would suggest we don't do any of these four? And that our response will be, we're gonna keep it in, but we're gonna prioritize it.
I didn't like the peer support thing personally. I guess, I don't know. It doesn't ring true to me as far as something that helps.
Okay, Daisy?
Yeah, the mobile crisis response. I understand completely the intent and the importance of developing the full crisis continuum in the state, having those positions be, centralized and, elevated into the state. And I understand the HMS did a really robust study on it, and this ask is, following that expert recommendation. But I also look at the $3 million request in vacancy savings and contemplate, why would we be throwing money at 4 more positions that are not going to get filled? They're just simply not. And when I look at the positions and, at the job descriptions, I question how fully baked the plan for those positions is. So I would not invest in the plan as it currently is fleshed out.
Which one, Daisy? I'm confused.
The mobile response.
Okay, mobile response. Okay, yep.
I have a question for you. Of the total 3.3 all funds, do we know how much is for the 4 positions?
We do, it's in there. No, I'll have to go back and look.
Do you know?
I do. For the record, Nicole DeSazio, I'm the Director of Policy for the Department of Mental Health. It's $211,000 and some change.
For all 4?
For the 4 positions. Yes.
That's general fund,
Yes.
but the gross is 422,812.
Yes.
Are those 4 positions limited service?
They are not. They would be full-time classified positions. And if I could speak to the vacancy savings, I just want to note that the vast majority of those vacancies are actually at the facilities. We don't have a lot of vacancies at central office, and that's where these positions would be located.
Okay.
Well, we did lodge a request about those vacancy savings and whether, we wanted to ask, something to the nature of those vacancy savings, whether those positions were in statute. And, to Art's point about give a little, take a little, and looking for savings as we're making these investments and recommendations to approach.
Not a bad.
It took 8 days to get a response from the department on those. And you can see posted to our committee page what the response was as to where those vacancies are at in the administration, if people want to look to that.
Okay. All right, so anyone else have a comment on mobile crisis?
I did want to point out that we took testimony from the DA in Rutland. Essentially said these are duplicative services to what they're already providing.
Yeah.
Okay,
So do I?
No, I realize that's just in.
it's just the one.
Yeah, but that's the idea of this is to spread this statewide,
Right.
have it available.
And it be coordinated.
Yeah.
Which you all know is like, I'm all about coordinating it. And so when I heard the provider in Rutland saying that, I thought, well, I also understand that, the element of competition, right? Like they want that for their providers. And there is, just a matter of business, right? Like you want that business. And when it's centralized and coordinated, that might mean a business impact on your local
Right.
model.
And I also want to remind everyone that when we heard testimony on this at the time, we were the state was in the middle of the RFP process and could not discuss with the person who would be awarded the contract, which is a designated agency on behalf of Vermont Care Partners. And so my hope is that those discussions, was the RFP awarded? Not yet. Once those discussions are be able to happen, that this will be much more fleshed out. And unfortunately, sometimes some of what we have to base our decisions on is timing. So I'm hearing not, like dental rates, we're like, yes, everyone, let's do this. So this could be a lower priority, but I'm also not hearing we take it out completely. Is that what I'm hearing?
Well, it's a pretty high priority for me, given what we've heard about the mental health crisis and keeping people out of the emergency room. And it may not be that the whole plan is baked yet, because things take time to roll out.
Right.
So I'm not, and you know a lot more about this than I do, given your research. But I worry about taking it out and then slowing down that process
Right.
of meeting people where they are and not in ERs.
Right.
So I put this down as a high for me.
Okay.
Because of that.
Okay. And I'm not advocating to take it out at all. I agree with you, Leslie. And it has been a priority of our committee in the past. I know we're a new committee, so I get that. But it has been a priority of our committee in the past, which is why we put funding towards the Rutland Mobile Crisis Response.
What would they do if they took, so they're a standard, the Rutland. I don't know if you guys know Dick Corsell, but I'm sure he was not a happy camper when they found out everything they did has to be disassembled.
Well, I don't know that we know that it has to be disassembled. Again, the conversations aren't able to happen between the agencies and Department of Mental Health. I mean, I think there is a need, right? There is a need for mobile crisis.
Yeah.
Let's remember that. Let's put that on the table, right? And so again, part of our issue here is, and I said this in the beginning, we're not going to have all the information that we want to be able to make our decisions. And this is one of those cases. And I put value on the fact that the DAs, Vermont Care Partners, and Department of Mental Health have worked together for a long time and will continue to work together on this. It's not some outside agency we don't know that's going to win this bid. It's not someone who doesn't know mental health is going to win this bid. So I just want to put that on the table. All right, so I'm going to say that right now we're keeping everything in. We're just going to prioritize it, except for those two where we're going to say we reject the governor's recommend. We want those programs to continue. And we're going to come back and do the one-time money after our break. And then we're just going to go through and do high, medium, and low. Fine.